This is Dr. Stone-Gale, and I'm going to just do a mini lecture on otitis externa as well as otitis media. When we think about the pathophysiology for otitis externa or swimmer's ear, the auditory canal, the external auditory canal itself is very warm, dark, and prone to becoming moist. So it makes it an excellent environment for bacterial and fungal growth. The skin is really very thin there. And so the canal can easily be traumatized by exposure to moisture, by skin conditions such as chronic eczema, or by infection of a hair follicle, or by trauma from maybe a fingernail, something like that, perforation of a tympanic membrane. And the common pathogens which are involved in otitis externa are Pseudomonas, Staph, or Strep. So Pseudomonas is the most common gram-negative, and Staph or Strep would be the most common gram-positives. There's also a fungal pathogen which can be present, and that in itself can be related to Aspergillus, which is the most common fungal pathogen. And then also Candida would be another fungal pathogen. There's also a viral component to this otitis externa also. These patients present with a rapid onset of ear pain. They have intense itching in the ear. They may have some purulent discharge. You may see some crusting of the ear drainage on the outside of the ear. They'll have some swelling and redness, and there's times when you cannot even get the otoscope in their ear because it's so swollen and you're not able to do anything. You can't even move the pinna. There'll be tenderness at the tragus and the pinna. They may have jaw pain, which is referred. And with the bacterial, you'll see more white mucus, but as they get into the fungal, black, grayish, like a fluffiness to the look of the discharge. You may see some yellow. I don't see that a lot, but I do see the fluffy white, black, and gray. The management of otitis externa consists of a few different things. Usually it's not necessary to go ahead and culture the patient because it's not really going to change your plan of care. You could remove cerumen either manually or with irrigation if they've got some impaction there and see if that will help too. If they're a diabetic, though, you need to be very cautious because if you irrigate a diabetic with water, then you run the risk of developing malignant otitis externa. And that's a medical emergency in a diabetic, so in anybody really. So you don't want to have that happen. So, think about not irrigating them with water. Anti-inflammatories, Tylenol for pain will help. And then thinking about antibiotic treatment. Once the external auditory canal has been cleansed as much as possible, then if the swelling's severe, topical antibiotic therapy should be started because topical agents can be placed in direct contact with the bacteria. So the use of non-sterile versus sterile is what has to be considered. If they have a perforated tympanic membrane, you do not want to put in anything with hydrocortisone in it. So ciprofloxacin would be out, myosin, polymyxin, hydrocortisone, otic solution would be out because they both have the HC in them. With the neomycin, it can produce permanent hearing loss due to cochlear damage, so you don't want to use that. With the Ciprodex otic solution, it is a sterile solution, so if they've got tubes, you can use it. If they've got the otitis externa, you can use it. And ofloxacin otic solution is one that can be used with a tympanic membrane perforation. And also, if they have tubes, you can go ahead and use that. Avoiding swimming for 10 days. You want to make sure that they do know that they shouldn't be swimming. And if they do want to go swimming, then they need to put earplugs in their ears. But it's highly recommended that they don't. Systemic oral antibiotics are rarely needed, but they should be used when the infection perceives to be spread beyond the confines of the ear canal. Also, if otitis externa is persistent and associated with acute otitis media, or if the patient is immunocompromised or even a diabetic, then you may want to consider that the topical agent just may not be delivered effectively, and you may need to maybe switch to Cipro 500 milligrams twice a day, or maybe even a broader spectrum antibiotic such as Augmentin. For prevention, you need to tell the patients to avoid any prolonged exposure to moisture, and they should really keep the moisture out of their ear for about 4 to 6 weeks. If you're going to use preventative antiseptics, then you should advise them to instill 2 to 3 drops of a 1 to 1 to 1 solution of vinegar and alcohol and water after each contact with water. So it's really beneficial for these patients with persistent OE also. And then using earplugs when swimming, and as well as avoiding swimming for at least 7 to 10 days if they have an infection. And then instructing them not to put any Q-tips or other foreign bodies in their ears. Anything smaller than the elbow should not really go in the ear. When looking at the definition for acute otitis media, it is considered to be a rapid onset of signs and symptoms of an inflammatory process that's occurring in the middle ear. If it is considered to be uncomplicated, then the patient will not have any otorrhea. But if it is considered to be severe, then they will be presenting with moderate to severe otalgia, and they may have a fever of equal to or greater than 102.2 degrees. And if it's non-severe, then they probably will have some mild to moderate otalgia, and their temperature may be less than 102.2 degrees. If they do have a recurrence of their acute otitis media, it would be if they have equal to or over 3 well-documented separate episodes in the past 6 months, or greater than 4 episodes in 12 months, or even greater than 1 episode in the past 6 months. This here is a really good picture of a patient who has otitis media, and you can see how it's erythemic, the tympanic membrane is bulging. So this is a real good view for you to see. Otitis media with effusion is thick or sticky fluid behind the eardrum in the middle ear, and it occurs without an ear infection. So there aren't really any signs and symptoms of infection that you see when you do look in the ear. The eustachian tube connects the inside of the ear to the back of the throat, and this tube helps drain fluid to prevent it from building up in the ear. The fluid drains from the tube, and then it is swallowed. So otitis media with effusion and ear infections are connected in 2 different ways. After most ear infections have been treated, then a fluid, which is called an effusion, remains in the middle ear for a few days or weeks. But when that tube is partially blocked, then the fluid does build up in the middle ear. And that's when the bacteria inside that ear becomes trapped and begins to grow, which then leads to an infection. So when I tell patients too what it looks like when I'm looking in the ear, I tell them if you've made green beans for dinner the night before and you're going to put them in the refrigerator for tomorrow, and you put saran wrap over them and you take them out tomorrow, you'll see that condensation, those bubbles, that fluid behind your saran wrap. And that's kind of what it looks like when you look in the ear. And that's what I kind of give patients an idea of, because they really don't understand. When you tell them they have fluid in their ear, they think they're able to get it out, and they can't get it out. On the other hand, there's chronic suppurative otitis media, and this is a chronic inflammation of the middle ear and the mastoid cavity. The clinical features of this are recurrent otorrhea through a tympanic perforation. So the tympanic membrane has ruptured. There's conductive hearing loss, and it may vary on how much hearing loss they have. The underlying pathology is an ongoing cycle of inflammation, ulceration, infection, and then it granulates. And then acute infection of the middle ear causes irritation and inflammation of that mucosa of the middle ear. when then there can be destruction of some of the surrounding structures, and there can be a lot of different, complications with this type of condition. Otitis media is the most common condition for which antibiotics are prescribed, and many have non-bacterial causes. In adults, it accounts for approximately 20% or less of the cases of otitis media. Some of the risk factors involved are smoking. That's one of the big ones, because secondhand smoke can cause problems. The recent upper respiratory infection, male gender, a family history, if they've had previous antibiotic uses, allergic rhinitis, upper respiratory infections, as I said. So some of those are significant risk factors for developing this. Adults are more likely to present with ear pain and drainage and decreased hearing and pharyngitis. And when you do the exam on the adult patient and it's normal, then you need to think about looking at, assessing the teeth, looking at the transmandibular joint, their nose, their pharynx, their cranial nerves, because these are some of the things that could be going on too, which are mimicking otitis. In looking at the management plan for otitis, there's a few things you can do that are outside of the pharmacological aspect. So then some of the non-pharmacological treatments would be the management of putting local heat on, uh, tr- referring them to ENT for a myringotomy, and even teaching the patient to swallow to ventilate that eustachian tube, which drains that fluid into the behind the tympanic membrane. Also, oral analgesics and for mild to moderate otalgias such as Tylenol and the anti-inflammatories do help substantially with this. With severe otalgia, narcotic analgesias with codeine may be necessary. And, unfortunately, the patients think that the minute you give them an antibiotic that they're going to get immediate pain relief. But antibiotics, even though, the pain management is important, the pain may be substantial, and the antibiotic therapy really does not provide that symptomatic relief in the first 24 hours. And sometimes they may even have it for 3 to 7 days afterwards. So, in severe acute otitis media, you do want to go ahead and treat them with antibiotics. If it is not severe, you may want to consider watchful waiting. And if you do decide to go ahead and place them on an antibiotic, then amoxicillin is really your first line antibiotic of choice. You need to consider the fact if the patient has not received amoxicillin in the past 30 days, or if they have not had recurrent purulent conjunctivitis, or if they have not had an allergic reaction to penicillin, or they do not need additional coverage for some type of a beta lactamase positive um, Haemophilus influenza or M. cataralis. If that's the case, then alternatives are needed for these specific patients. But amoxicillin usually will be the one you grab first, 500 milligrams or 875 twice a day, and you do want to go ahead and treat them for 5 to 7 days. If they do have a penicillin allergy, you could consider a cephalosporin, although it is really recommended that you find out what kind of allergy they had. If they had any type of anaphylaxis or rash or difficulty breathing, then you may not want to consider that because there is a 10% cross-reactivity with a penicillin allergy. And at that time, then you may want to go ahead and just prescribe a macrolide. And you could use azithromycin, Biaxin, or any of the erythromycins.